Hello everyone, happy evening, a very good evening. I hope and I believe all of you are doing well. A quick note everyone, am I audible and visible everyone? Yes? Just a minute, I'm putting this. Okay, that's great, guys. So I have already uploaded the blank PDF for this session on my Telegram group. I've also pinned the link for the same. So if you want, you can get the PDF from there. And post session, the annotated PDF will be uploaded in Medsynapse app. Right in the free content folder where you have the sprint course, which is there, a free course. All these videos are uploaded in the Medsynapse app at one place with the blank and annotated PDFs for each. So this is the fifth subject, I believe, that we have in the SureShot sprint. Before this, we have done anatomy, physiology, biochemistry, and pharmacology SureShot sprint. All of that is available in the Medsynapse app for free. Okay, right? So let's start. These SureShot sprint sessions are basically your sneak peek and into the SureShot entire sessions that we have had on Medsynapse app. For the students who have already watched SureShot, this is going to be like a quick revision with active recall rather than just passive revising SureShot. And for the students who are not there as SureShot subscribers, like it's going to be a good revision for you guys as well with all the mnemonics. Okay. So let's start with the discussion. First, we'll start. The first topic that I'm discussing is ECG. Of course, this is not everything in medicine. A lot of other topics have been discussed in medicine, SureShot, Extra Edge, the nephrology part, the neurology part, endocrinology part. With all the tricks and mnemonics, it has been discussed in Extra Edge video again on the Medsynapse app. Okay, पहले हम ECG quickly revise करते हैं because many of you had asked for this कि quick revision of ECG चाहिए. So let's do it first. So tell me that in a standard ECG setup, what lead is, what limb is designated as the ground electrode? The right upper limb or the left upper limb, the right lower limb or the left lower limb, which is the ground electrode? Right? I want this session to be very interactive. So please keep answering in the live chat. Let's see who answers the questions fastest and the most accurate, right? UPSC students, you have exam tomorrow, so maybe you can revise something else. You can watch this video later on at a faster speed for if you want a last minute revision of this for your exam tomorrow. Okay, rather than watching it live, you can watch it later as well. Is it the left foot? Why everybody is saying left foot and everybody is saying left foot? I mean, I am doubting myself now कि ground electrode left foot होता है कि right foot होता है? Yes. So finally, somebody has mentioned it is Sumaya Sheikh. It is the right foot. Okay, it is the right foot which is the ground electrode. It is not the left foot, right? We remember it with it's always right to stay grounded, right? It is always right to stay grounded, correct? So remember, it is the, where did my screen go? Just a minute. Right, it's the right foot. So remember it as right on the ground. It's right to be on the ground. Okay, to be grounded. That's how you remember. So you remain on the ground with the foot. So it is right foot, not the left. Okay, next one. What in ECG represents a ventricular depolarization out of PQRST? What represents ventricular depolarization? It is the QRS complex, which is ventricular depolarization. That means it is marking the onset of ventricular systole or diastole. Remember, in the heart, it is electromechanical event. First is the electrical, the depolarization. Then is the mechanical, that is the contraction. So it is marking the onset of ventricular systole. And that means what heart sound will come now? What heart sound will come? Is it S1 or is it S2? Remember, for diastole, okay, the trick is diastole starts with S2. So systole is going to start with S1. Okay, systole is going to start with S1. Correct? What represents ventricular repolarization? After QRS comes T. So that is going to be ventricular repolarization. That means it is S2. The diastole is what will start now. So it is going to be S2 heart sound. Okay. Next one, coming to ECG revision, digoxin effects in ECG. What does it do to QT, shortening or QT prolongation? Remember, for digoxin, QT becomes choti, right? Rhyming, QT is choti. What happens to PR? PR for PR is prolonged. Okay, so PR prolongation, QT choti, that means QT shortening is there. And there is ST segment, depression or elevation. Remember, ST is ST, depressed. It is not elevated. A scooped ST segment depression, which is also called as Salvador Dali mustache sign. So the trick is QT choti, PR prolonged, and ST is depressed. Okay. And what happens to T wave? T is ulti, that is T wave inversion is also seen. So look at the image here, the Salvador Dali mustache sign, where you can see this ST segment depression, the hockey stick, reverse tick mark sign also it is called. Okay. Coming to WPW syndrome, the Wolff-Parkinson-White syndrome, which is basically the accessory bundle of Kent which is there. Along with the AV node se jo ja raha hai normal pathway se, there is accessory bundle of Kent transmitting from the atrium to the ventricle. It conducts faster, right? So when I say it is conducting faster as compared to the routine path, how is going to be the PR interval? The PR is going to be short, right? Because there is faster conducting bundle of Kent. Now, because the ventricle is stimulated by accessory pathway, not the normal pathway. So remember, anything abnormal leads to QRS broadening. So it is short PR but broad QRS. And what wave is there? It is delta wave, right? The upstroke is not sharp in the QRS. You can see this slope like thing which is there in the QRS. It is not going straight like this. It is going like a slope, that is called as delta. Okay, so short PR, broad QRS and delta wave is what you have in WPW. And remember, the drugs which are AV nodal blocking drugs, they are contraindicated because you do not want this accessory bundle to win. So you will not give something which is blocking the AV. Which are the drugs blocking AV? Remember, A, B, C, D. AV blocking drugs is B for beta blocker, C for calcium channel blocker, and D for digoxin. So beta blocker, calcium channel blocker, and digoxin, A, B, C, D. These are AV blocking drugs. So digoxin is also AV blocking, and that is why you see PR prolongation with digoxin, because it blocks the AV. Okay? Right? Coming to tachyarrhythmias, supraventricular tachycardias versus ventricular tachycardias. How do you differentiate? Supraventricular tachycardias, they have narrow QRS. Ventricular tachycardias, they have broad QRS. Okay. So PSVT shows narrow QRS complex with absent P wave, because the P wave gets merged in the QRS there in PSVT. So look at the ECG here for PSVT. You can see that the QRS is narrow. Okay, and there is tachycardia. Okay, if you look at the heart rate, it's going to be high. You are not seeing the P wave. You are seeing this QRS and T wave. The P wave is hidden. Okay, it's an absent P wave. Look at the rhythm. How is the rhythm? It is regular rhythm. It is not irregular. If it was irregular, then you would think of atrial fibrillation with absent P wave. So PSVT is going to be narrow QRS. The first line drug of choice for stable patients is adenosine. And how do you give adenosine? IV adenosine. If the patient is unstable in PSVT, any unstable patient, you will go for cardioversion. Okay, then in that case, the answer will be cardioversion. So before answering question on PSVT, please have a look at whether the patient is stable or unstable. Okay, right? Torcidus de pointus, remember it is that twisted ribbon, the party ribbon appearance, where you see like this appearance, which is waxing, waning, ऐसा वाला appearance दिखता है, बढ़ता है, कम होता है, यहाँ पे you will see this appearance, that is Torcidus de pointus. What is the drug of choice for Torcidus de pointus? It is magnesium sulfate. Remember Torcidus de pointus, it is magnesium sulfate. Atrial fibrillation. Remember, in atrial fibrillation, there's a risk of LA thrombus developing, which can embolize and lead to stroke, and that is why we give anticoagulant. So, if that the left atrial enlargement, atrial fibrillation, which is there, is because of mitral stenosis or prosthetic valve, then what anticoagulant do you give? Do you give the Novax, the newer oral anticoagulant, or do you give warfarin? Remember, the trick is for valvular cause, that is mitral stenosis, or it could be mitral prosthetic valve. You give VA is VA, then you give warfarin. So, in that case, the drug of choice is warfarin. So, rheumatic heart disease hai, prosthetic valve hai, you would give warfarin, and if not, then you will give Novax. Which are the Novax? Which are factor 10A inhibitors, or which is the oral direct thrombin inhibitor? It is dabigatran. Okay, dabigatran or factor 10 inhibitors. So, what score do you use to assess कि anticoagulant देना है कि नहीं? Remember, you have this Chad's-Wesk score. Okay, that is Chad's-Wesk score, which is used in atrial fibrillation to assess the risk of stroke and hence the need for anticoagulant. Next one, if it is irregular rhythm with more than 3 different P wave morphologies in patient of COPD, what is that arrhythmia that we are talking about? It is MAT, multifocal atrial tachycardia. From multiple foci in the atria, you are getting this tachycardia, and that is why every P wave coming from different focus is going to have different morphology. Classically, a history of COPD is there. So remember, it is MAT. And what is this image showing? Look at the rhythm here. The RR interval, it is not constant changing. You are not seeing the P wave. This is going to be atrial fibrillation. Irregular rhythm with absent P wave. Okay, you treat it with calcium channel blocker for MAT. Okay, for multifocal atrial tachycardia, you give calcium channel blocker. Going to next one, in AV block, right? When the AV is getting blocked, the first thing in first degree AV block, what is the ECG change? Because the AV is not conducting. So the PR interval which is there, that is going to be prolonged. So you will just see PR prolongation. That's the first thing with AV block. Okay. And what is this AV block? Where you have progressive PR lengthening and then there is a dropped beat. What degree of AV block is this? So remember, when you have dropped beat, okay, the trick to remember is dropped beat. Dropped is though, that is second degree heart block. When there's a drop beat, the QRS is absent, check for the PR interval. If it is progressively increasing and then there is a drop, that is Mobitz type 1. Remember, Mobitz is by, that is second degree heart block, which is also called as Wenke-Bach phenomenon. Okay, remember Wenke-Bach is Mobitz type 1. Wenke-Bach phenomenon, progressive increasing. While Mobitz type 2, it has constant PR interval which is prolonged, but there is going to be drop beat. In first degree heart block, you have prolonged PR which is constant but no drop beat. In Mobitz type 2, you have a dropped beat also. That is how you differentiate. And in third degree heart block, complete heart block, atrium on its own, ventricle on its own, right? That is a third degree heart block. Remember here, the RR interval is going to be regular. Okay, ventricle wala RR is going to be regular, PP is going to be regular, but the P and R have no relation. Both of them are on their own. Okay, so remember, what is the classical infectious cause of third degree heart block? Which infection can cause this third degree AV block, complete heart block? Yes, anyone? Which infection can cause third degree heart block? Very good, absolutely right, Tasneem. Correct, it is Lyme disease. right? Lyme disease, Borrelia burgdorferi, the bullseye rash, target rash, which is there. Lyme disease is very important cause of AV block. Okay. Going to bundle branch blocks. Bundle branch blocks, how is the QRS there? Again, it's a broad QRS complex. How do you differentiate right bundle branch block from left bundle branch block? So look at this. RBBB. R is for marrow having double R. It's the mnemonic for RBBB. And William having double L. That is for left bundle branch block. So when I say marrow, it's basically M coming first and W coming last. So M pattern in V1 and W pattern in V6. So look at this one. This is the M pattern. Okay, this is the M pattern that you are seeing. R, S, R dash pattern. And this is where the S is prominent. This is like called as W pattern. So this is going to be right bundle branch block. Opposite here, if you see in V1, William में W in V1 and M in V6, that is going to be William, that is left bundle branch block. Okay, clear with everyone? So if you have W in V1 and M there is M in V6, it's William, it is going to be left bundle branch block. While RBBB will have ulta, it's going to be M and W. Left bundle branch block will have W and M. Going to MI, I'm not going into the entire detailed topic of MI, we have discussed in SureShot, but tell me most important. If you see ST elevation in the leads 2, 3 AVF, then it is what wall MI? Anterior, anterolateral, is it inferior? What MI is it? When it is 2, 3 and AVF, it is what wall MI? Remember AVF, F for the foot. Foot, where is the foot present in the body? Inferior. So remember it is inferior wall MI. Inferior wall MI. That means what artery is blocked in the inferior wall MI? Remember it is right coronary artery. And this right coronary artery is generally what supplies the SA node and AV node. And that is why in inferior wall MI, you will also commonly have bradycardia which is present. SA node affected, bradycardia will also be present there. Okay? So what is the earliest change in ECG in MI? Is it the Q wave, ST elevation or something else? It is tall T waves called as hyperacute T waves. Tall T waves is the first thing, right, that you see in MI. Okay, that's the first thing that is there. Followed by ST elevation, and then you have Q wave which is suggestive of some old MI. A prominent Q wave is suggestive of an old MI. Okay? Versus pericarditis is also something which has ST elevation. But remember in MI, it is vascular territory limited, while in pericarditis, the entire pericardium affected. So the entire myocardium affected, it is going to be diffuse ST elevation. What kind of ST elevation? Is it concave upwards or convex upwards? Is it concave or convex upwards? What kind of ST elevation is it? Yes? So how do you remember this? Pericarditis versus MI, which is a more benign condition, pericarditis. So the patient is happier with pericarditis rather than the MI. So pericarditis wala patient is smiling. MI wala patient is sad. So remember that with pericarditis, it is like this, which is concave upwards. While in MI, it is convex upwards. Tombstone appearance in MI. It is concave upwards. And what do you see with PR segment? There's going to be PR segment depression. PR is depressed, ST is elevated. Except in what lead do you see the reverse changes? Remember in the lead, AVR. R for reverse changes. That is how you can remember. R for reverse changes is what you have in the lead, AVR. Okay, right? Going to JVP. In complete heart block, what waves do you see in complete heart block? The atrium is contracting against the closed tricuspid valve. There is no relation between atrium and ventricle. So very tall A wave, which is called as Cannon A waves. Okay, Cannon A wave is seen in heart block. On the other hand, A wave is absent in what condition? The A wave is because of atrial contraction. So in what condition atrial contraction is absent? Atrial fibrillation, right? So remember there, the A wave will be absent in atrial fibrillation. Okay, atrial fibrillation. Coming to this one, where do you see Beck's triad? Beck's triad is constrictive pericarditis or cardiac tamponade. Remember, it is cardiac tamponade which has Beck's triad, right? Tamponade, a lot of fluid or blood accumulating in the pericardium suddenly. So you have the Beck's triad, which is hypotension, muffled heart sounds, and a high JVP. Remember, you have the vein coming into the heart and from there the artery going. So related to vein, JVP is high. Related to heart, because of the fluid, the sounds are decreased and the blood pressure is low. It is hypotension. This is the Beck's triad. And what do you see in JVP in cardiac tamponade? With the X and the Y descent, both present, both absent, one absent, what do you see? Absolutely right, there is absent Y descent and a steep X descent. How do you remember this? Is remember like tamponade, it is like when there's tamponade, TATA, remember tax. So you pay increased taxes, right? Increased taxes without any reasoning in India, right? There is no why to it. There's no reason to it, but you have to pay increased tax. Who pays increased tax? Remember Beck. To remember, it is Beck's triad. So Beck pays increased tax without a why, okay, without a reason to it. So there is no why, there is absent why in tamponade, okay. And remember, versus in constrictive pericarditis, what do you have in constrictive pericarditis? Remember constrictive as K, K, K. There is pericardial knock, there is Kussmaul sign positive. What is Kussmaul sign? JVP increasing during inspiration. Rather than going down, the JVP is increasing. And both X and Y are present. They are steep in constrictive pericarditis. Okay. Remember, in constrictive pericarditis, CP is CP combined present. Both of them are present. None of them is absent in constrictive pericarditis. Very, very important. Okay. And what do you see in X-ray of constrictive pericarditis? Remember, it is calcific constrictive pericarditis, common with TB in our country. So you would see calcification surrounding the heart. Pericardial calcification surrounding the heart is what you would see. Calcification will be present. Okay. Going to next one. What are the causes? Acid-base disorders. What are the causes of NAGMA? Normal anion gap metabolic acidosis. What are the causes of NAGMA? Remember who's NAGMA? NAGMA is our Didi. That is how we have remembered from a SureShot mnemonics, correct? NAGMA kaun hai? NAGMA Didi hai. So Didi for diarrhea and diarrhea. What are the two kinds of diarrhea? One is the GI wala normal diarrhea and the other is the renal diarrhea, which is renal tubular acidosis. Renal tubular acidosis is nothing where the tubule is defective and that is why there is diarrhea happening from the tubule. So remember, it is diarrhea, that is the normal GI diarrhea, or it is renal tubular acidosis. Okay? What helps you differentiate the two is urinary anion gap. So what anion gap tells you? It's a GI wala diarrhea, a negative or a positive. Remember, negative in gut cause. Gut cause GI diarrhea has negative anion gap. A positive anion gap, urinary anion gap is what we are talking about, is renal cause. Okay. And then there is this formula, Winter's formula is used in metabolic acidosis to calculate the respiratory compensation. Kitna hona chahiye? Matlab PaCO2 kitna hona chahiye to say that it is compensated or not compensated. The formula is 1.5 into bicarbonate plus 8, and to that you do plus minus 2. Okay. What happens in metabolic acidosis with pH, PCO2 and bicarbonate? Remember, in metabolic disorders, ME, it is all same direction change. In acidosis, the pH decreases, so the rest of the two also decrease. The PCO2 also decreases, the bicarbonate also decreases. Same direction में जाते हैं तीनों के तीनों. Similarly, in metabolic alkalosis, all the three will increase. Okay, remember the mnemonic ROME. Respiratory opposite, metabolic equal. We have discussed this in our SureShot sessions. Next one, very important, salicylate, that is aspirin toxicity, will have what acid-base disorder? It causes a mixed acid-base disorder. What is that mixed acid-base disorder? Yes, this has been asked in one of the recent UPSC CMS exam as well. Very, very important. Salicylate causes what acid-base disorder? Metabolic and respiratory. Metabolic में क्या, respiratory में क्या? Remember, salicylate is salicylic acid. So it's like we are taking an acid. So it is going to be metabolic acidosis. And it causes opposite of that, respiratory alkalosis. Why respiratory alkalosis? Because it stimulates the respiratory center in the brain. So hyperventilation causing respiratory alkalosis. So it is metabolic acidosis. What kind of metabolic acidosis? Nagma or Hagma? It is Hagma. It is high anion gap. Okay, it's high anion gap metabolic acidosis. Correct. Then you have renal tubular acidosis. What type presents with hyperkalemia? Remember, RTA type 4 has more. That is the rhyming thing. 4 has more potassium. 1 and 2, they have less potassium. Okay, there is hypokalemia. Only in 4, it is more. And type 4 RTA, remember 4, when I write, it is like what alphabet hidden in 4? It is alphabet A. So it is because of aldosterone deficiency or aldosterone excess. Remember 4 wala alphabet is D, 4D. So it is aldosterone D, that is deficiency. Anything which is leading to aldosterone deficiency, so addisons or aldosterone antagonists like spironolactone. So you remember spironolactone diuretic, it causes hyperkalemia. Okay, it causes hyperkalemia. Similarly, ACE inhibitors, they will cause hyperkalemia. Okay. Next one. What organism causes neonatal meningitis and has a tumbling motility? Remember, it is Listeria. Listeria has tumbling motility and it's an important cause of neonatal meningitis, especially when there is history of premature rupture of membranes, right? Premature rupture of membranes. And the drug of choice for Listeria is ampicillin. Okay, the drug of choice is ampicillin. What culture medium do you use for Listeria? From our SureShot microbiology session, what is the mnemonic for that Listeria? Remember, when everything is tumbling down, you make a list. So Listeria tumbling motility. And when you have pulcum, timeless, pulcum matlab less time, you make a to-do list. So remember, pulcum jab hai, list banao, so it is pulcum media. Okay, pulcum media. Next one, in what meningitis do you have normal glucose? That is very, very important. If the CSF glucose is normal, it is normal glucose is seen in viral meningitis. Okay, remember virus does not eat glucose and that is why it is going to be, okay, that is why it is going to be normal glucose. Then you have TB or fungal mein kya hota hai? There is going to be lymphocytosis, while in bacterial meningitis, wherever there is bacteria, remember it is neutrophils. So there are high number of neutrophils. PMNs is what it is called, will be high. Both of them will have low glucose, high proteins, but the difference is in the cells. And remember, for induction for cryptococcal meningitis requires what drugs? It is amphotericin B plus fluconazole or flucytosine. Remember, it is flucytosine, not fluconazole. Important. It is not fluconazole. Fluconazole is for the maintenance phase. Induction is amphotericin B and flucytosine. Okay. Next one, what encephalitis classically involves the temporal lobes? Temporal lobes are affected. Classically in what organism encephalitis? HSV. Encephalitis is what HSV? 1. Above the waist 1, below the waist HSV 2. So genital 1 is going to be HSV 2. So this H for HSV encephalitis is generally hemorrhagic, right? So the CSF has RBCs present and you will give acyclovir for treatment. Acyclovir is what you will give for HSV encephalitis. Going to myasthenia gravis versus Lambert-Eaton, which is presynaptic and which is postsynaptic affected. Remember the trick is L पहले आता है, M बाद में आता है alphabetically. A, B, C, D, F, G, H, I, J, K, L, M. L comes first. So presynaptic is Lambert-Eaton. Postsynaptic is going to be myasthenia gravis. Okay. So remember this is postsynaptic myasthenia gravis. And you have Lambert-Eaton, which is presynaptic. What channels? Calcium channels which are affected. Okay, it is affecting the voltage gated calcium channel, and this is acetylcholine receptor postsynaptic. Okay, and in Lambert-Eaton, remember the strength improves with repeated use, versus in myasthenia, with repeated use activity the patient feels fatigue more. So there is more fatigue, more ptosis in the evening. Okay, that's very, very important. Plus, Lambert-Eaton has autonomic features, deep tendon reflexes, which are depressed. All of this have been discussed in our Medsynapse app videos, right? Next one, in SLE, you have anti-dsDNA and anti-Smith antibodies, which are specific for it. And if it is drug-induced lupus, then what antibodies do you have in drug-induced lupus? Remember, drug, when you are suspecting drug-induced SLE, you take a history of drug. Like what drug the patient has taken. So you take drug history. So history is histone. It is anti-histone antibodies. What drugs cause SLE? The ship drugs. Sulfonamides, hydralazine, INH and procanamide. Okay, that's procanamide. Okay, procanamide, hydralazine. Next one. In the limited scleroderma, which is CREST syndrome, remember C for C, you have what antibody? Anti-centromere antibody. Okay, this anti-centromere antibody. Versus in the diffuse type, SCL scleroderma sclerosis, it has anti-SCL. Okay, scleroderma has anti-SCL70, also called as topoisomerase 1, and it is predictive of interstitial lung disease. The interstitial lung disease is common in the diffuse type. Which condition do you have this anti-Jo one? That is anti-synthetase antibody, Gottrin's papules, lilac rash, shawl sign. All these are present in dermatomyositis. Okay, it is dermatomyositis which has this anti-Jo antibodies. And what cancer will you screen for when there is dermatomyositis? Ovarian cancer. Okay, remember CA 125 check karenge ovarian cancer ke liye. Very, very important. Next one, what is this condition which is linked to this anti-beta-2 glycoprotein? There is recurrent spontaneous abortion. There is prolonged APTT which is seen. What is this condition? Recurrent abortions हो रहे हैं in a female. Hypercoagulability वाली state है. What is this condition? It is APLA वाला syndrome. Right, anti-phospholipid antibody positive APLA syndrome, recurrent abortions, hypercoagulability, DVT can be there. It is anti-beta-2 glycoprotein. Okay, anti-beta-2 glycoprotein. Correct. Sjogren syndrome has what antibodies positive? Remember, Sjogren. Jo is not anti-Jo, but it is Ro. So it is anti-Ro, anti-La, anti-Ro-La. It is anti-Ro, SSA and SSB. Remember it is like Sjogren syndrome A, Sjogren syndrome B. ऐसे याद कर सकते हो anti-Ro-La. Okay, so Sjogren syndrome, anti-Ro-La, and remember Ro-La crying wala. So you do that test in Sjogren's because of the dry eyes. What is that test? The Schirmer test for the dry eyes. Okay, so there is that keratoconjunctivitis सिक्का होता है, dry eyes होता है, dry mouth होता है in Sjogren. And it has a significant risk for B-cell maltoma. Remember, malt wala lymphoma is what is common here. Inflammatory conditions, it has maltoma. Okay? And then you have finally here, what is this condition which has classically albuminocytological dissociation in the CSF? The albumin is high, but the cells are low. Right? What do you see in meningitis? कि प्रोटीन हाई है, साथ में सेल्स भी हाई होते हैं. यहाँ पे albumin हाई है, लेकिन सेल्स नहीं हाई है. So what is this condition? Correct. It is GBS, Guillain-Barré syndrome. And it is generally associated with what infection? GBS. It is Campylobacter jejuni. Okay, remember Campylobacter jejuni infection. And in what condition do you have oligoclonal bands in the CSF? Oligoclonal bands in the CSF are seen in multiple sclerosis, right? It is seen in multiple sclerosis. Okay. So that was about the today's quick session, guys. Major focus being on ECG quick revision. It is not as difficult as it seems. At least the most important must know ECGs is what you should know, how to approach it. For ECG questions, you have to go retrospective, look at the options and then decide what is fitting into it. Okay. And the details of acid-base disorder with all the tricks, even delta ratio has been discussed in SureShot. And in medicine, SureShot Extra Edge, we have discussed a lot of other topics like neurology, stroke localization, spinal cord Wale syndromes, then nephrology, endocrine, that has been discussed in the Extra Edge in Medsynapse app, right? So yes, that was about the quick today's session. We shall keep having, we'll have more such sessions in the coming days as well. So please stay subscribed to this channel with the notification on so that whenever there's a session which is planned, you get a notification of it. And also remember, please do not miss giving the mini GTs on the Medsynapse app, because we have 10 mini GTs that I've planned. It's like one section of NEET PG, 36 questions in 42 minutes. And they are all based on PYTs. Okay, PYQs and PYTs, not the PYQs as it is, but definitely with some twist, right? So rather than solving questions which are irrelevant, I would highly recommend that you solve these mini GTs, which are purely based on the previously asked questions and topics, and see how do you fare on them. Rather than doing the PYQs again and again so much that you remember the question and the answer with the option itself, solve the PYQs with a twist, which you will see in the mini GTs. The next mini GT we have is tomorrow, right, 2nd of August. Okay. Is this clear with everyone? Right. So we have Anshuman. Thank you so much, Anshuman, for getting back 3 years later in the final year of orthopedics. Amazing. You know, it always feels so good to hear back from the past students. Thank you so much. And I hope you are doing well. And all the very best for your PG exams as well. Would be waiting to hear post PG also. Okay. All right. Thank you so much everyone for joining in. Again, a reminder, the annotated PDF will be uploaded in the Medsynapse app. Free course mein sprint mein add hoga with the other subjects which have already been covered. Anat, physio, biochemistry and pharmacology. Those are also available in the app already with the PDFs. Right. And thank you so much for reminding. For all the students appearing for UPSC CMS exam tomorrow, all the very best. Please use all the tricks that we have learned on how to logically guess the answers in UPSC CMS exam, how to rule out the options, right? UPSC does test a lot of your, mental ability, how you can think logically when you are in the exam hall. So please pay attention to it. Do not just look at the question and start panicking ki ye to pada nahi, ye bhi nahi pada. A lot of questions you can solve logically. Revise all those 3 subject videos for every subject that we had, right, even today, with the reference tables from textbook. That's absolutely important. And do let me know tomorrow, how was the exam. I'll be waiting to hear from you. So all the best to all the UPSC CMS aspirants. Thank you so much, guys. Goodbye, take care, and keep studying, keep revising, keep Medsynapsing, and keep winning. Thank you.